Welcome to the Funnel Effect. Today, we're doing a really critical deep dive. We're looking into the incredibly complex world of the mitral valve. It's a mechanical marvel, really, inside the human heart. But crucially, it's also the ultimate anatomical gatekeeper. It decides who qualifies for these cutting-edge, often life-saving procedures when surgery isn't an option. Our journey today takes us right into the source material. It's a groundbreaking paper called Mitral Valve Anatomy, Pre-Procedural Screening and Imaging Techniques. This analysis was published in Eurointervention back in 2015. The authors are Ariana Gonzalez Gomez, Sarah Fernandez Santos, Covadonga Fernandez Gulfin, and Jose El Zamorano. They really laid out the map, for understanding the challenges of these transcatheter repairs. Okay, let's unpack this then. Our mission today really is to get grips with the clinical crisis that's driving this technology. We're talking about treating severe mitral regurgitation. That's when the valve doesn't close properly, causing a massive leak back into the atrium. And we're focusing on patients who, well, simply couldn't survive traditional open heart surgery. So this deep dive isn't just about breaking down the valve's complex architecture, the apparatus itself. More importantly, we want to reveal why its dynamic, constantly moving parts demand such incredible millimeter-level precision. And we'll look at what specific anatomical features, or maybe lack of them, can actually disqualify these really high-risk patients from getting the treatment they need.
That really is the core challenge, isn't it? Mitral regurgitation, MR as we call it, it's far from a minor issue. It's a significant chronic cause of morbidity and mortality. And its overall prevalence, it's surging. That's directly tied to our aging population and, of course, the rise in chronic heart failure cases.
Yeah.
So for patients who are too frail, perhaps too old, or maybe they present with really severe left ventricular dysfunction, multiple other health problems,
Yeah.
open heart surgery just isn't on the table. It's too risky.
Right. Too much for them to handle.
Exactly. And this profound clinical need, this gap in treatment options, needing something effective without needing to crack the chest open, without cardiopulmonary bypass. That's what has fueled this really intense development of percutaneous, catheter-based interventions.
Yeah.
But, and this is critical, we have to emphasize that the challenge, it really starts and ends with the mitral valve itself. It's not just some simple flap. It's a complex anatomical and functional unit. You've got the leaflets, the annulus or ring, the subvalvular structures like the cords, and the whole dynamic environment of the left ventricle working together. And because this anatomy is so intricate and frankly so variable from person to person, doing these percutaneous interventions remains highly challenging. It demands the sort of meticulous pre-procedural planning that we're really going to focus on today.
Okay, so to really grasp the technical difficulty of repairing this thing, we have to start with the basics, the foundation. Let's look at the valve structure itself, maybe starting with the leaflets, the parts that actually meet or coapt to seal the valve. You've got two main ones, the anterior and the posterior leaflets.
That's right. The anterior leaflet, it's quite large, sort of trapezoidal in shape. And surprisingly, even though it's large, it only covers about 1/3 of the whole circumference of the opening, the annulus.
Only a third. Interesting.
Yeah, and it's often called the aortic leaflet, too. That's because its base is actually continuous with the fibrous structure of the aortic valve right next to it.
Okay, and the posterior one?
Well, in contrast, the posterior leaflet is more quadrangular, sort of rectangular shaped, and it occupies the remaining 2/3 of that annular circumference. This size difference is really important functionally. Now, to make communication easier, for surgeons and interventionists to pinpoint problems, both leaflets are conceptually divided into 3 segments. We call them scallops.
Right, the A1, A2, A3, and P1, B2, P3 naming convention.
Exactly. A1, A2, A3 for the anterior, and P1, P2, P3 for the posterior.
This kind of anatomical mapping is absolutely essential for planning any precise surgery or device placement.
But there's a key difference in how those scallops are defined, isn't there?
There is, and it's crucial to understand this because it's often misunderstood. While we conceptually divide the anterior leaflet into 3 parts for mapping, it's actually the posterior leaflet that's the only one with visible anatomical indentations that truly define its 3 segments, P1, P2, and P3.
Ah, so the posterior ones are physically marked, but the anterior ones are more like designated zones. Precisely. And that A2P2 region, right in the middle, being the central and largest part of the valve overall, that's overwhelmingly the most common target area for repairs, like the MitraClip device.
Makes sense to aim for the biggest target. And these 2 leaflets, they meet at the edges, right? Forming the commissures?
Yes, 2 distinct commissures. You have the anterolateral commissure, that's where A1 and P1 connect. It's located very close to the opening of the left atrial appendage. which is a key landmark, by the way, for cardiologists doing transeptal procedures.
Okay.
And then there's the posteromedial commissure. That's where A3 and P3 join up. It sits adjacent to the interventricular septum, the wall between the ventricles, and also near the tricuspid valve on the right side. Understanding the spatial relationship of these commissures, where they are in 3D space, is really vital, especially if you're dealing with MR jets that are very off-center, very eccentric, or originating right from the commissures themselves.
But as you hinted, the real complexity maybe it lies less in the leaflets themselves and more in the base they attach to the mitral annulus.
Indeed. If you're picturing the annulus as just, a simple flat ring like a washer, you're making a fundamental mistake right there.
Okay, correct me.
The mitral annulus, it's this fibrous three-dimensional structure. It defines the junction point between the left atrium, the left ventricle, and the valve leaflets themselves. The sources really emphasize its distinct three-dimensional saddle-shaped appearance. Think of, I don't know, a Pringle potato chip or maybe a Western saddle. It has high points,
Near the aortic valve.
right, near the aortic valve and on the opposite side, and then it has low points, sort of dips mid-anteriorly and mid-posteriorly. It's not flat at all.
And it moves.
Oh, absolutely. What's really fascinating here is its profoundly dynamic nature. The whole MV apparatus doesn't just sit still. Throughout the cardiac cycle, with every heartbeat, the annulus changes shape, and critically, it changes size.
How much change are we talking?
During systole A, that's when the left ventricle contracts and pressure builds up high. The annulus area actually reduces by as much as 25%.
25%? That's huge.
It is huge. And this reduction, it's an essential active mechanism. It helps pull the leaflets closer together, aiding in optimal coaptation, ensuring they make a perfect seal against that high ventricular pressure. So any static, rigid device like a clip or a ring has to operate within this environment that's perpetually moving and changing its footprint quite significantly.
That dynamic movement, all structure shifting like that, that must be the central antagonist, the main challenge for any static catheter-based technology, right? If the valve moves and changes size by a quarter with every beat,
Precisely.
a fixed clip or a fixed ring has to somehow accommodate that massive mechanical variation.
Exactly. And the structural difference across the annulus is also key to understanding pathology, why things go wrong. We mentioned the anterior part of the annulus is tough. It's continuous with the aortic annulus, forming what doctors call the aortic mitral curtain.
Right.
This strong fibrous connection makes that anterior section stable, quite rigid, and it represents the highest part of the annular plane, the peak of the saddle, if you like.
But the back part is different.
The posterior segment, however, is much weaker structurally. It lacks this robust, fibrous skeleton. It's more loosely anchored to the surrounding heart muscle, the myocardium. And this structural difference is profound. Because that posterior segment is structurally vulnerable, that's why annular dilatation, the stretching and widening of the ring and subsequent calcification, hardening, occurs disproportionately in those posterior two-thirds of the annulus in patients with various heart diseases.
So the weakness is where the stretching tends to happen.
That's where functional MR often begins, right there in that weaker posterior segment.
Okay, now let's look beneath the leaflets. The critical support system that stops them from just blowing backwards into the left atrium when the ventricle squeezes. That's the subvalvular apparatus.
Correct. That consists of the chordae tendineae and the two papillary muscles.
Chordae tendineae, the heartstrings.
Often called that, yes. They're fibrous strings, often likened to parachute cords. They originate from the papillary muscles.
Which stick out from the ventricle wall.
Right. They arise from about the apical third of the left ventricle wall.
Oh.
And these chordae insert into the free edges and also the body of the mitral leaflets, maintaining that perfect tension needed during systole to keep the valve shut tight.
And the papillary muscles themselves, you said there are two.
Two papillary muscles,
Right.
but perhaps they're the most anatomically vulnerable components, particularly when you think about blood supply. You've got the anterolateral papillary muscle and the posteromedial papillary muscle.
Okay.
The anterolateral one is pretty robustly protected, gets a dual blood supply from two major coronary arteries, the anterior descending and the circumflex. So it has a backup, essentially, a functional redundancy.
Makes sense. What about the other one?
The posteromedial capillary muscle, well, that's in sharp contrast. It's typically irrigated by a single source, branches that come from either the circumflex or the right coronary artery, depending on the person's coronary dominance.
Only one supply line.
Only one. And this single irrigation source is a critical distinction. It explains why the posteromedial muscle has a significantly higher susceptibility to ischemia, to lack of blood flow. If a patient has a heart attack, a coronary artery occlusion affecting that single supply line, the posteromedial muscle is much, much more likely to fail and fail acutely.
And what does that acute failure look like clinically? We're talking pretty catastrophic failure, aren't we?
We really are. Look, if the anterolateral muscle suffers injury, that dual supply often mitigates the damage. Maybe it weakens but doesn't completely fail. But if the posteromedial muscle loses its single blood source,
Oh.
it can undergo rapid necrosis, basically tissue death, or even rupture completely. This instantly leads to acute, massive, catastrophic mitral regurgitation. We're talking a life-threatening condition causing flash pulmonary edema, fluid in the lungs, and cardiogenic shock almost immediately.
Wow.
This specific anatomical vulnerability drives one of the most severe and dangerous forms of misarrangement.
Okay, so that covers the valve structure itself. But finally, the ultimate driver, especially for functional MR, is the left ventricle itself, right? The sources remind us that the LV's health, its shape and size, are inseparable from how well the valve works.
Absolutely inseparable. When a patient develops any form of cardiomyopathy, whether it's ischemic, due to coronary blockages causing damage, or non-ischemic, like a primary heart muscle failure, the LV often begins to remodel.
Mm.
It changes shape, usually dilating, getting bigger,
Stretches out.
stretches out. And as the LV chamber enlarges, the distance between the apex, the bottom tip of the heart, and the mitral annulus at the top increases. This pulls the papillary muscles downwards and outwards, away from the valve. We call this process tethering,
Tethering, like pulling on ropes.
exactly like pulling on ropes. And this tethering is the direct mechanical cause of what we call functional MR, often classified as type TIE third, according to Carpentier's system. The pull on the papillary muscles and the chordae prevents the leaflets from achieving optimal coaptation, from meeting properly in the middle. They get pulled down, restricted in their motion, and this creates a gap, usually a central leak.
And then the key insight here.
The key insight, and this is crucial for understanding treatment, is that in functional MR, the valve leaflets themselves are structurally normal. They aren't torn or floppy. The failure is one of geometry and support, driven entirely by the diseased, enlarged ventricle beneath it.
So fixing it isn't just about patching the leaflet.
Not at all. This makes treating functional MR profoundly different and often much more challenging than treating structural degenerative MR, where the problem is the leaflet itself.
Okay, so given all that complexity we just discussed, the dynamic shape, the vulnerable structures, it forces us to seek these really precise, minimally invasive solutions for those high-risk patients. And the most established, the most widely used percutaneous technology out there right now is the MitraClip system.
That's right. MitraClip has been the pioneer in this space.
Can you walk us through the mechanism? It's quite clever, but also very targeted.
It is. It's a catheter-based device. It's navigated up through the venous system, typically the femoral vein in the leg, up into the right atrium of the heart. Then you perform a controlled puncture across the atrial septum, the wall between the atria, to get into the left atrium. This is called transeptal access,
A key maneuver in itself.
a very key maneuver. Once in the left atrium, the device is positioned directly over the mitral valve. And what it does is mimic a specific surgical technique, the Alfieri edge-to-edge repair.
Okay, Alfieri edge to edge. What's the goal there?
The goal of the MitraClip is to grasp and securely hold the free edges of the leaflets together. Typically, as we said, it targets those central A2 and P2 segments. By pulling these two segments together and clipping them, it essentially transforms that single large leaking orifice into a smaller, more functional double orifice. Think of it like creating a figure-8 opening instead of a single large hole.
And that reduces the leak?
Precisely. This reduction in the effective regurgitant orifice area can dramatically reduce the amount of blood leaking backward, which in turn improves the patient's symptoms, their quality of life, and hopefully their survival.
And the evidence supports this.
Yes, the clinical evidence, particularly from landmark trials like Everest 2 and COAPT, has really confirmed the MitraClip procedure as a feasible and relatively safe alternative, specifically for those high-risk patients who are considered ineligible for open surgery.
But its success hinges entirely on that anatomy we detailed earlier.
Absolutely. It's fundamentally predicated on specific anatomical criteria. The leaflets have to be healthy enough, mobile enough, and critically close enough together for the clip to successfully grasp them. If the anatomy isn't right, the clip won't work.
Okay, so MitraClip is elegant for leaflet problems. But as we noted, for many types of MR, especially that functional MR driven by the LV getting bigger, the main issue isn't the leaflets, it's the ring, the annulus stretching out. That's why annuloplasty procedures were developed, right? To try and mimic the surgical rings that surgeons use to reshape and shrink the annulus.
Exactly. Surgical annuloplasty, putting in a ring, is often key for achieving effective and durable surgical results. So Percutaneous annuloplasty devices aim to replicate that, mainly for patients with type I MR, which is pure annular dilation, or that type 5 functional MR, where you have restricted leaflet motion due to the LV enlargement and tethering.
Let's start with the really ingenious, maybe slightly flawed indirect annuloplasty approach, the one using the transcoronary venous route. It uses the heart's own plumbing, essentially.
It's quite fascinating conceptually. It leverages the anatomical relationship between the posterior mitral annulus and the coronary sinus, which is a large vein, and the great cardiac vein. This vein complex wraps around the posterior part of the mitral annulus. So interventionists realized, hey, maybe we can insert a shortening device, some kind of anchor or cinching system, into this vein.
Inside the vein.
Inside the vein, yes, to indirectly pull on or cinch or reshape the posterior annulus geometry. It's like pulling the strings on a purse to close it. It's an elegant way, potentially, to reduce that septolateral diameter of the annulus without directly touching the delicate valve tissue itself.
But relying on that vein structure, that sounds incredibly tricky, especially given the anatomical variability we talked about.
Yeah.
The critiques I've read highlight some major limitations here.
They absolutely are major limitations, and the sources really stress the need for sophisticated imaging, often cardiac multi-detector CT or MDCT, just for screening these patients. There are two big hurdles.
Okay, what's the first?
First, the distance between the coronary sinus vein and the actual mitral valve annulus is highly variable between people. If this distance is too great, which often happens in very dilated hearts, the shortening device simply lacks the mechanical leverage needed to effectively pull on the annulus. The procedure might become futile, it just won't work.
Right, not enough pull.
Not enough pull. Second, and this is the more dangerous one, is the intimate, but again highly variable, relationship between the coronary sinus and the left circumflex artery, the LCX.
Ah, the coronary artery running nearby.
Exactly. The LCX is a critical blood vessel supplying the side and back walls of the left ventricle. It often runs directly adjacent to, sometimes even tucked under, the coronary sinus right where these devices would sit. So if the device shortens the vein too aggressively, or if the anatomy is just unlucky and they're already extremely close, the device could inadvertently compress or kink the LCX.
Causing a heart attack while trying to fix the valve.
Precisely. That compression leads to severe coronary ischemia, a major heart attack, during an attempt to fix the valve leak. The precision required to avoid hitting the LCX and the variability essentially limits the number of patients who are even suitable candidates for this indirect technique.
Okay, so given those limitations, the restrictive nature and the high risk of the indirect approaches, the field naturally moved towards direct annuloplasty, right? Trying to reproduce the surgical ring placement more accurately by anchoring devices directly onto the annulus itself.
That's the logical next step. Direct annuloplasty involves getting access either transeptally through the left atrium or sometimes retrogradely, going backwards through the aortic valve into the left ventricle. And the goal is definitely to provide a more durable, more effective annuloplasty by directly targeting that dilated ring structure.
But as you can imagine, the technical complexity just skyrockets.
Because you're anchoring into moving tissue. You're talking about placing anchors, screws, or other fixation elements directly into tissue that is actively moving, changing shape with every beat, and is part of this complex 3D saddle structure. It's incredibly challenging.
What are the main drawbacks here?
Well, they're numerous. First, managing pre-existing annular calcification. If the annulus is heavily calcified, hardened, it can be very difficult or impossible to get secure anchor placement. Then there's the potential for damaging the delicate mitral leaflets themselves during device delivery and deployment. And again, that persistent risk of damaging the nearby circumflex artery, which still runs close to the posterior annulus.
It seems the fundamental challenge remains.
It does. The requirement to anchor some sort of fixed or semi-rigid device into a dynamic, non-planar saddle-shaped structure remains the paramount engineering hurdle for direct annuloplasty.
And the failure of some systems really drives this point home. The source material briefly mentions the icoapsy system that aim to fix MR by reducing the septolateral distance of the ventricle using external pads and a sort of bridge across the ventricle.
Yes, the icoapsis was another interesting approach.
But wait, if LV dilation is the main cause of functional MR, and the goal is to reduce that side-to-side septolateral dimension to relieve the leaflet tethering, why did a device designed specifically to do that, the icoapsis, ultimately get stopped? It sounds like it targeted the root cause.
That's a really profound question, actually, for understanding the complexity of MV pathophysiology.
Hmm.
The icoapsy system, conceptually, it tried to treat the problem as mostly a 2D issue, just a simple widening side to side.
Okay.
However, as we've established, the mitral valve apparatus operates in 3 dimensions. While the device did often reduce that septolateral dimension acutely, it frequently failed to adequately address the apicobasal dimension, meaning the degree of leaflet tethering, the pulling down into the ventricle from apex to base.
So it squeezed it side to side, but didn't lift the leaflets up enough.
Exactly. The overall 3D geometry, the saddle shape, and particularly the apical tethering of the leaflets were often insufficiently corrected. This led to significant residual NR, or maybe the fix wasn't durable long term. Ultimately, its development was halted.
A technical failure highlighting the 3D complexity.
It really underscored how interconnected and complex that 3D geometry is. You can't just fix one dimension and expect the whole system to work perfectly.
Okay, so we have a highly successful but very anatomically restrictive repair strategy with MetriClip. We have several annuloplasty strategies that are limited by technical complexity and risk to nearby structures. That brings us to the future, doesn't it? Transcatheter mitral valve replacement, or TMR.
Yes, TMR is often seen as the next frontier, the potential holy grail for some patients. But the contrast with aortic valve replacement is just stark.
Why is TMR so much harder than TAVR, the aortic valve replacement we do routinely now?
Well, we've essentially mastered transcatheter aortic valve replacement, TAVR, because the aortic valve sits in a relatively well-defined, mostly static fibrous cylinder. It's a good landing zone for a prosthetic valve.
Right, more straightforward geometry.
Much more straightforward.
Mm.
The mitral valve, in contrast, is everything we've just discussed. It's dynamic, it's saddle-shaped, it's tethered by active muscles, it lacks a uniform fibrous ring for anchoring, especially posteriorly where it's weakest. So TMR technology has to overcome a whole host of additional issues. How do you get secure anchoring in a non-cylindrical moving shape without the valve migrating or leaking around the edges? How do you avoid obstructing the outflow path from the left ventricle, which sits right underneath the anterior leaflet? How do you avoid embolization, bits breaking off, or disrupting that crucial subvalvular apparatus?
It sounds incredibly difficult.
It is. That is fundamentally why mitral valve replacement via catheter is proving to be infinitely harder than mitral valve repair, and certainly much harder than aortic valve replacement. So given the absolute need for precision with these repairs, the role of imaging becomes absolutely central, wouldn't you say?
Couldn't agree more. And the undisputed king here, as the source emphasizes, is echocardiography. It's the main technique for everything. Patient selection, guiding the intervention itself, evaluating the results immediately after, and detecting any complications.
That's right. And while standard surface echo, the one done on the chest wall, gives you a good initial look, transesophageal echocardiography, or TOE,
The probe down the throat?
exactly, the probe down the esophagus. TOE is considered mandatory for assessing any potential MitraClip candidate. It simply provides superior image resolution and better positioning because you're closer to the heart, enabling that comprehensive, detailed anatomical and severity assessment that's necessary for planning such a high-stakes procedure.
Okay, so before we dive deeper into the specific anatomical measurements needed for the clip, we first have to establish, is the leak actually severe enough to warrant taking the risk of an intervention in the first place?
A crucial first step.
The procedure is generally only indicated for moderate to severe or severe mitral regurgitation.
Yeah.
And quantifying that severity you mentioned often starts with 2D/2OE, specifically using the PISA method, proximal isovolumetric surface area.
Yes, PIUS is a common starting point. It looks at the area where blood flow converges as it accelerates towards the leak. From that, you can calculate two key numbers, the effective regurgitant orifice area, or EROA.
That's the size of the hole, essentially.
The effective size of the hole, yes. And the regurgitant volume, or RV, how much blood leaks back with each bead. These two numbers are the fundamental indicators of how bad the leak is.
But here's where it gets really interesting and maybe counterintuitive. The thresholds that define severe MR aren't the same for everyone, are they? They differ significantly based on why the patient has MR in the first place, the underlying etiology.
That's absolutely right. And it reflects the different clinical impact of the leak depending on the underlying heart condition. It gets complex here.
Let's break it down. For primary MR, that means structural disease, usually degenerative prolapse where the leaflets themselves are floppy or damaged.
Right. The valve itself is the primary problem. For that group, Severe MR is typically defined by an EROA greater than 40 square millimeters and a regurgitant volume of 60 milliliters or more per beat.
Okay, 40 and 60, that sounds like a lot of leakage.
It is a massive leak. But often, in primary MR, the heart's pumping function, the left ventricle, is reasonably well compensated, at least initially, so it can tolerate that level of volume overload until the later stages of the disease.
Okay, but now compare that to functional MR, the secondary
Right.
kind, the one driven by the LV failure and enlargement we discussed earlier. The definition of severe MR uses vastly lower thresholds here.
Vastly lower.
Yeah.
For functional MR, severe leakage is defined as an EROA greater than just 20 square millimeters and a regurgitant volume of only 30 milliliters or more.
Wow, that's a staggering difference. EROA of 20 versus 40, RV of 30 versus 60. A patient with functional MR is considered severe, with literally half the measurable leakage of a primary MR patient. Why?
And that's the crucial clinical insight that you really have to emphasize. Why the lower threshold? It's because patients with chronic functional MR, which is driven by underlying severe left ventricular dysfunction, they simply have much, much lower physiological reserve. Their ventricles are already failing, already weak.
They just can't handle the extra work.
Exactly. They cannot cope with the volume overload created by even a moderate leak by primary MR standards. Clinically, a leak of 30 milliliters in a struggling heart failure patient is often just as debilitating, just as life-threatening, as a 60 milliliter leak in a patient whose LV structure is relatively preserved. The severity isn't just the absolute volume, it's measured against the capacity of the failing system.
That makes perfect sense clinically. The patient is fundamentally sicker to begin with. Okay, so we have these thresholds, but traditional 2D2E quantification, like PISA, it relies on some geometric assumptions, doesn't it? Like assuming the flow convergence area is a perfect hemisphere?
It does, and that assumption can lead to errors, particularly if the regurgitant jet is very eccentric, not nice and central, or if the orifice shape is complex. This is where 3D TOE really steps in and offers an advantage.
How does 3D help?
Well, the power of 3D TOE is that it allows for direct measurement, manual planimetry, of the vena contracta area. The vena contracta is the narrowest cross-sectional area of the regurgitant jet right at the valve level.
Like the pinch point.
Exactly, the pinch point of the leak.
Wow.
Measuring that area directly using 3D planimetry requires no geometric assumptions about the flow upstream, so it can provide high accuracy regardless of how eccentric or strangely shaped the jet might be.
But you wouldn't rely on just one method.
No, the recommendation is generally for an integrated approach. Use 2D PISA, use Doppler volumes, use 3D vena contracta area, combine the information, because no single method is perfect in all situations.
Got it. Now, beyond just quantifying the leak, imaging, especially 3D, is vital for evaluating the cause, the etiology, and mechanism.
Absolutely. The sources underscore that before even considering something like NutriClip, we must confirm the patient has either organic lesions, typically degenerative prolapse, or functional ischemic MR, the secondary kind. Other causes, like rheumatic disease or endocarditis in the active phase, often contraindicate the procedure.
And 3D gives you that surgeon's view.
That's the common analogy, yes. By visualizing the entire mitral valve apparatus in a single and-face view, looking down from the left atrium, or sometimes up from the LV.
You can see the whole valve at once.
You see the whole thing, and you can precisely identify which specific scallops, A1, P2, P3, whatever, are prolapsing or flail or restricted in their movement. This level of spatial detail is often impossible to piece together reliably just from 2D slices alone. So knowing the exact morphology, the shape of the problem, and the precise origin of the MR jet is paramount for planning where to put the clip, or if the clip is even appropriate.
And connecting that visualization back to procedural success, the location of the jet matters hugely, particularly for MitraClip.
Absolutely critical. The clinical data consistently shows that central jets, those originating from that main A2P2 segment coaptation line, have yielded the best results with the MitraClip.
Why is that?
Well, simply because the MitraClip device is designed primarily for central application. Yeah, it physically creates that new, smaller double orifice right there at the A2P2 level.
Oh.
If the main regurgitant jet is highly eccentric, maybe coming from way over at the posteromedial commissure near P3, then placing a clip centrally might fail to capture the leak effectively, or it might only reduce it marginally, leaving significant residual MR.
So the anatomy has to be favorable in terms of where the leak is coming from. The bulk of it needs to be central for the clip to work best.
Precisely.
Okay, and one final key screening point that goes beyond just measuring a leak. We have to assess the risk of accidentally creating a new problem, right? Mitral stenosis.
Correct. You fix the leak, but you don't want to cause a blockage. The procedure must not significantly restrict the forward flow of blood from the left atrium into the left ventricle during diastole. So during screening, we carefully assess the leaflet tissue quality. Is it excessively thick? Is it heavily calcified? And very importantly, we use imaging, often 3D TOE again, to measure the initial mitral valve area, MVA. The goal is to ensure that the post-procedural MVA after the clip is placed will still be sufficiently large, generally considered to be greater than 4 square centimeters. If placing the clip is predicted to result in an area smaller than that, it might cause significant mitral stenosis, and the patient essentially trades one life-threatening condition for another.
So 4 centimeter hot is the magic number to avoid stenosis. All right, this section feels like where the rubber really meets the road. We're talking about possibly the tightest anatomical restrictions in all of interventional cardiology because the MitraClip is it's a fixed device, right? It has set dimensions, certain maneuvering limitations based on the catheter. Patient selection becomes constrained by these really rigid, sometimes unforgiving millimeter level measurements.
That's absolutely the case. These aren't just guidelines. They are often hard requirements based on the device's capabilities and the clinical trial data.
So beyond the general prerequisites we just discussed, needing that baseline valve area over 4 centimeter decide to avoid stenosis, and having acceptable tissue quality, meaning not too much calcification, especially in the grasping zone, the source says the single most important prerequisite overall is simply the presence of sufficient leaflet tissue for the clip to mechanically grab onto. Is that right?
That is fundamentally the most important factor. If the leaflets are too retracted, maybe scarred and short, or if there are massive holes or defects in the tissue, the clip simply has nothing reliable to grasp and anchor to. The procedure is technically impossible or doomed to fail.
Assuming there is enough tissue, then we get into the specific numerical criteria, which were largely defined by the big clinical trials like Everest.
Exactly. These definitive numerical criteria were established and validated primarily through the seminal Everest trials. And these specific measurements dictate whether the clip can physically, successfully grasp the tissue, effectively reduce the MR, and, crucially, remain securely attached long-term without tearing the leaflet.
And we need to look at these criteria differently depending on the cause of the MR, the etiology.
Yes, the key measurements differ because the underlying problem is different. Let's start with patients who have degenerative MV prolapse, the floppy valve type, primary and visitor. Here, the key issue is the excess floppy tissue. So we focus on two main measurements that define how bad the prolapse or flail segment is: the flail gap and the flail width.
Okay, let's break down the flail gap first. What exactly is that measuring?
The flail gap is the distance, measured usually in millimeters, separating the very tip of the flail or prolapsing segment, the part that's bending back too far from the opposing, relatively healthy leaflet during systole when the valve is supposed to be closed.
And there's a strict limit on that gap.
There is. That gap must be less than 10 millimeters. This is often considered a hard limit, typically measured using 2D TOE in a long-axis view.
Why 10 millimeters specifically? Is that arbitrary?
It's not arbitrary at all. It's dictated by the mechanics of the MitraClip device itself. The jaws of the clip are designed to open to a certain extent and securely grasp tissue across a certain maximal distance. If the leaflets are separated by more than 10 millimeters, the device may either fail to capture both leaflet edges properly, or the tension required to pull them together that far would be excessive, risking tearing the tissue or having the clip detach later on. So that 10 millimeter number comes directly from the device design and limitations.
Okay, 10 millimeter flail gap. What's the second measurement for degenerative disease? Flail width.
Right, the flail width. This measures how wide the prolapsing or flail segment is, side to side the portion of the leaflet edge that is detached or is billowing backward excessively. This width must be less than 15 millimeters. This measurement is usually derived from the intercommissural view on TOE, looking across the valve opening.
And the rationale here, too wide is bad.
If the flail segment is wider than 15 millimeter, the problem is that placing a single standard MitraClip, which has a certain width itself, will likely fail to adequately address the entire area of regurgitation. You'd clip the middle, but you might still have significant leaks remaining on either side of the clip.
So you might need more than one clip, or it might just not be suitable.
Exactly. These two numbers, flail gap 10 millimeters and flail width 15 millimeter, are really the fundamental anatomical prerequisites for MitraClip success in degenerative disease based on the Everest criteria.
Okay, that's clear for degenerative. Now, let's switch gears to functional MR, the secondary kind, driven by the ventricle enlarging and tethering the leaflets down. The measurements must shift here, right? Because the problem isn't excess floppy tissue, it's tissue that's restricted and pulled down.
Precisely. The focus changes completely. For functional MR, we measure coaptation length and coaptation depth.
Coaptation length first. That's how much the leaflets overlap when they close. And it needs to be at least 2 millimeters.
Yes, exactly. We need at least 2 millimeters of overlap, or coaptation length, during systole for the clip to have something substantial to grab onto and hold securely. If the leaflets are barely touching or not quite meeting, the clip grasp will be tenuous and unstable. Generally, the greater the coaptation length, the better the chance of a durable result.
Makes sense. Now, the really challenging one, I think, for functional MR is the coaptation depth. This measures how far down the leaflets have been pulled or tethered below the level of the mitral annulus plane.
That's correct. And this is often a key limiting factor. The coaptation depth must be no more than 11 millimeters below the annular plane.
Again, a very specific number, 11 millimeters. Why that limit?
This 11 millimeter limit is pretty non-negotiable in most guidelines, and again, it links directly back to the physics and mechanics of the delivery system and the clip. If the leaflets are tethered deeper down than 11 millimeters into the ventricle, the mitral clip delivery catheter might struggle to reach that deep and articulate properly to grasp the leaflets effectively. Furthermore, the clip itself would have to pull the tissue up excessively far to achieve closure,
Creating too much tension.
creating way too much tension on the leaflets and chordae, again risking tissue damage, tearing, or clip dislodgement over time. It also becomes physically harder to maneuver the clip arms in that very deep, restricted space within the tethered ventricle.
And the LV shape matters here, too.
It does. In patients with advanced functional MR, the LV often remodels and becomes more spherical, less conical. This further restricts the space where the clip needs to operate deep inside the ventricle. So yes, every millimeter coaptation depth really counts.
These specific criteria, 10 gap, 15 width for degenerative, 2 length, 11 depth for functional, they really underscore that technical tightrope you mentioned earlier.
They absolutely do, achieving perfect grasping and positioning on tissue that's constantly moving within a complex 3D space, all while adhering strictly to these restrictions based on device mechanics. It's incredibly demanding.
And before we wrap up the checklist, we have to remember screening also includes the approach, right? Getting the device there safely. You need to assess the left atrium size and the septum.
Yes, absolutely. We need to assess the dimensions of the left atrium. A very large, massively dilated LA can sometimes make navigating the catheter and manipulating the device more difficult. And crucially, the interatrial septal morphology needs careful evaluation. Not just looking for a patent-form and ovale, a PFO, which might need consideration in the overall assessment, but primarily for planning the transeptal puncture itself.
Where you cross from right to left atrium.
Exactly. The location, thickness, and angle of the septum dictate the trajectory the catheter system has to take to cross into the left atrium and then approach the mitral valve at the correct angle and height to position the clip accurately over that A2-B2 target zone.
So an anatomically challenging septum may be very thick, maybe very floppy, maybe awkwardly positioned, can severely impede successful device delivery, even if the valve anatomy itself looks suitable.
That's correct. The access road is just as critical as the target anatomy.
Huh.
Hashtag, outro. So if we try to synthesize this deep dive, I think the fundamental realization has to be that the mitral valve is just an exceptionally complex, highly dynamic, and from an interventional standpoint, anatomically very restrictive structure. Now, the development of transcatheter techniques, particularly MitraClip, it represents a genuine revolution. It's treating patients who previously were often just consigned to medical therapy alone with poor outcomes. That's undeniable progress.
Huge progress.
Huge. However, this success has forced the entire field, cardiologists, imagers, surgeons, engineers, to focus with a really unmatched intensity on understanding mitral valve anatomy in minute detail. The precise assessment of all these dimensions, these movements, the tissue characteristics we've discussed, it's absolutely non-negotiable for procedural success and for patient safety.
And imaging is key.
Echocardiography, especially TOE, is the undisputed central imaging modality. It guides everything. But, this raises an important point, or maybe a question. While the MitraClip offers this powerful alternative, these rigid, restrictive anatomical criteria, we've painstakingly outlined those precise EROA thresholds that even adjust for how sick the ventricle is. The non-negotiable flail gap less than 10 millimeter, that coaptation depth limit of 11 millimeter. All of these underscore that these procedures demand extreme precision. Patient selection remains a highly technical process, defined almost entirely by the limitations of fitting relatively static mechanical devices into this incredibly dynamic biological environment. It's not for everyone.
So, what does this all mean then, stepping back? The success of MitraClip, it's a real testament to the power of cleverly mimicking one specific surgical repair, the Alfieri stitch. But when you consider the profound complexity of the mitral valve that we've spent this time discussing, its dynamic saddle shape, its constant motion, its critical tethering to the LV, its immediate proximity to vital coronary arteries, it tells a much bigger story about the limits of current technology, doesn't it? We kind of mastered TAVR relatively early because, as you said, the aortic valve is fundamentally simpler structurally. It sits in a nice cylinder. So given the sheer difficulty in just finding a secure anchor point for anything in the mitral position, avoiding blocking the LV outflow, maintaining durability in that non-cylindrical, constantly moving plane, consider this. How much further away are we realistically from achieving that ultimate goal, a truly safe, reliable, widely implantable percutaneous mitral valve replacement compared to where we are with the aortic valve? It seems like the gap between the aortic solution and the mitral solution remains a really profound measure of just how challenging the anatomical complexity is within the human body.
It's a huge gap,
Yeah.
and closing it is one of the major challenges in cardiology today.
Thank you for watching The Funnel Effect.